Good afternoon, guys and gals. My name is Sandra Hansel. Most people call me Sandy around here. And I am the one and only inpatient diabetes educator here at the infirmary. I do occasionally go to North and Morrilton, not all the time, but with extreme cases, you never know where I'm going to show up. So, a little bit about my background. I started out in nursing as an acute hemodialysis nurse, and from there I went into diabetes education back in 2006, but coupled that with the stint in critical care as well as going to a cardiac nursing floor. Matter of fact, that's where I started at St. Vincent North here back in 2012. So. I've done diabetes education with both inpatients and outpatients, gestational. What's been great about being here is I've gotten my experience with insulin pumps. So I've done a lot of hands-on stuff here that I've never been able to do anywhere else. Today we're going to do something a little bit different than the typical lecture as far as orientation goes. First of all, who in here has critical care experience? Okay, so we've got one in critical care, med-surg, lots of med-surg, OR, cath lab. We have to have one, at least one in the class. Okay, so we've got our differing abilities here in the class, and we're going to try to see if we can get you all together on the same page. Now, what we're going to do initially is talk about what is involved in what I refer to as diabetes management, or basically glucose management. What is it going to take from you, the nurse, to be able to manage the glucose of your patient while they're here with us in the hospital? So our goal for that is to have their glucose usually range between 140 to 180. Now, some people, they're going to be a little bit different than that, but that is the overall goal for glucose here in the hospital. Now, to do that, we have to actually look at several different things, and what I refer to as the clinical picture of your patient. Now, who in the hospital, as far as healthcare workers, should actually know the clinical picture of your patient?
The nurse.
The nurse? Who else?
Dietitian.
Yes, if they reviewed the chart.
Mm-hmm.
Okay.
The patient.
The patient. Oh, so you said the patient. Yes, obviously they're very important, but she mentioned the nurse. I'm also going to say the one other individual that I hope knows the entire clinical picture of the patient is also our doctors.
Mm-hmm.
So really and truly, for us to manage the patient, your nurse has to know what's going on, your doctor needs to know what's going on. So what are some of those things that we actually look at that we include in the clinical picture of the patient so that we can manage them? So for instance, glucose you're managing. Where is the sugar coming from that we are actually trying to control? What two places does sugar come from?
Food.
Food. Okay, so we know that the largest spike in sugar is going to occur about an hour after you eat. But I'm going to give you a little hint because we're going to do this case study in a second, and you're going to need to know this other fact. If your patient has gastroparesis, their food does not peak in 1 hour, it actually peaks in 2. And that may be very good to know if I'm trying to work clinically through my case study on my patient, okay? So we've got food. Everybody knows food. We preach food, we talk about food with people with diabetes. What's our other source of glucose?
IV fluids. IV fluids.
IV fluids inside the body already.
Liver.
Liver. Thank you so very much. Okay, so if I am getting sugar from my liver, how often is it giving me sugar? When does your liver need to give you sugar?
I believe it's just a reserve.
Say that again?
I believe it's just a reserve, if in case.
It's a reserve in case.
Mhm.
Actually, we're getting sugar from the liver 24 hours a day, 7 days a week. And the reason we get that sugar from the liver is because our brain happens to be 98% dependent on the fact that we always maintain the normal amount of sugar, 70 to 120, at all times to be able to continue to function. Okay? So, your liver, think of it as if it is snowing sugar in your bloodstream all day, all night long. However, there may be times when your liver gives you even more sugar. So think of it like a blizzard. So what do you think some of those times are that you may have overproduction of sugar coming from the liver?
When they skip their meals.
When they skip their meals. Yes, so what's going to happen? We're going to have something called glucagon. Glucose is gone, released from the pancreas that tells the liver to release extra sugar. All right, so let me ask you this question. Are our patients here in the hospital because they're on holiday? I know some of them think they are, but not usually. Why are they here? Why do they come to the hospital?
They're sick.
They're sick. They're having surgery. So they have things going on with them. There are things that cause all of us, whether you have diabetes or not, to be more insulin resistant. During those times of insulin resistance, it means that the liver is not just giving us a little bit of sugar, it's giving us a lot extra. So, what that means is, when I look at the 6 causes of insulin resistance, and I'll go through them quickly, and y'all can't ask me questions. The first one is genetics. So in families where there are lots of individuals who have diabetes, they're born with an insulin-resistant gene, which means the day they're born, their pancreas is having to overproduce insulin in response to that extra sugar that's coming from their liver. Okay. These are my young diabetics that are newly diagnosed. They're in their 20s and their 30s and their 40s. Okay. Second cause, those of us that are a little bit overweight or a lot overweight, okay? We are going to be insulin resistant all day, all night long. So if you think about it, people who have diabetes, especially type 2 diabetes, 80% of them are overweight. And so that is a huge movement to get people to lose weight whenever they have diabetes, to help lower how much sugar their body needs and how much insulin. So the next one is inactivity. So the more inactive we are, and it's not what we do day to day, but the more inactive we are, the more insulin resistant we are. Exercise can lower insulin resistance for 24 to 48 hours after I stop moving. Okay? The next thing is major mental stressors, and you would not really imagine how often I talk with patients, and I do get to know them and their brothers and their sisters. But I find out when I go through this list with them, I do know that maybe somebody close to them has passed away. One of the saddest stories I came across was a woman who actually had lost her brother, and 2 weeks later she found out she had diabetes, but then right after that she found out she had non-Hodgkin's lymphoma, and soon passed away after that. These are major stressors on the body, and your body will respond by telling that liver to release extra sugar. Okay? And that is not something that usually your patient is going to be able to control. The next thing is physical stressors. Again, we work in a hospital and people are sick. So we know that the number one cause of DKA is an infection. Second cause is they don't take their insulin. But let's go back to the infection. So any infection, illness, injury, pain, nausea, vomiting, diarrhea, surgery, procedures, these are things that put stress on the body. When I'm working on CV step down and they've just had a cabbage, I know their body needs 10 times the amount of insulin that it normally does. And that's why so many people go home on insulin following that type of procedure. The last thing on our list are medications. So what is the granddaddy medication of them all that we know that actually causes your blood sugar to go up?
Steroids.
Steroids. Okay, and it comes in many different forms, whether it's a shot after a sinus infection, the shot in the joint, and you'll be surprised, doctors forget to ask about those sorts of things, but I hear it a lot from the patients, even hydrocortisone cream. The fact is, though, that there are 5 pages of medicines that actually impact blood sugars. And so things like that, that we typically give, beta blockers, diuretics, oncology medications. When I have my behavioral health people in here, they can tell you that things like Zoloft, Abilify, they have as big an impact on blood sugar as sometimes those steroids that we're very concerned about, okay? So that's one of the things. So when our patients encounter these causes of insulin resistance, it means that the liver is our biggest source of sugar that we are trying to manage. Now, nutritional status, do you think that's important whenever you're trying to take care of your patient, to know how much they're eating? And if I'm going to give them some insulin or something and we know that they're not really eating, can I give this medicine safely to my patient? Is it a good idea? Glucose trends. So I recently had a patient that basically his blood sugar would go up to 500, and then we would turn around and we would try to give him some correctional insulin and he would drop to 38. So seeing that, knowing that, we had to really back off on how quickly we gave him insulin. If it was a little bit, we just had to make very small changes. If he was eating, we had to be aware that, hey, stop not giving his basal insulin because he's going to shoot up as soon as you stop. Because the liver doesn't stop giving us sugar, okay? Planned procedures. If I go to the OR, do you know what your blood sugar should be within the perioperative period for best outcomes of that particular patient? Not really? Okay, so evidence shows us that if our blood sugars stay below 190 in that perioperative period, before, during, and after for at least 48 hours, you're going to have better outcomes and you will have less problems with surgical site infections. So glucose control and your surgical patients become extremely important in that realm. What if a nurse or a doctor decided not to, or you've got a patient who has type 1 diabetes, and we'll talk about that in a second, and they didn't get their basal or background insulin. If they didn't get their basal and background insulin and yet they came to you, what do you expect that blood sugar to do by the time they come to you? Go up. Now, unfortunately, most people think it's the opposite, that they didn't get anything, so maybe it'll go down if they gave them too much insulin. So too many times, nurses are not giving the basal insulin to a patient who has a procedure if they're not thinking about the next thing, insulin dependence. So you've got a patient who has type 1 diabetes. How much insulin are they making?
0.
Very little.
Very little, none, or less than 5%. Exactly. Can you have a type 2 diabetic who's also very insulin dependent? Absolutely. As we all get older, we all make less insulin. So it's inevitable that people will reach that stage. And yes, we'll all be diabetics. Y'all can say, Okay, so insulin dependent. So I've got a type 1 diabetic. How long can they go without insulin in their system before their risk of going into DKA begins? Guesses?
12 hours.
12 hours?
You lost me at questions.
Okay. Okay, you got a patient. You gave them insulin 6 hours ago. Maybe some rapid acting, some Novolog.
Oh,
How long before their risk of going into DKA begins if they no longer have any insulin within their bloodstream?
right, so the insulin is worn off and now their sugars are starting to climb.
Right.
So if it's regular insulin, right, or Humalog,
Okay.
that would be roughly 6 hours out.
For regular, yes.
Yes.
Okay, so they haven't had their regular. We're at 6 hours out.
Yeah.
How long do you have to make sure they get more insulin?
Before they end up in DKA.
Before their risk begins. Doesn't mean they will,
Um,
but that's when their risk begins.
yeah, 12 hours.
12 hours? 1 hour.
1 more hour.
1 more hour before the risk begins, because once their blood sugar reaches, for some it's 200, for some it's around 240, that's where their risk of going into DKA begins.
Right about hour 7 then, from start to finish. Okay.
If we're doing regular.
Yeah.
But you have to know the duration of action of your insulins to be able to know the answer to that question. And this is something that most nurses do not recognize, okay? But it's one that is probably one of the most important things that you have to be aware of. It's why we do our Lantus 2 hours prior to transitioning to or turning off our insulin drip, because we have to know that that Lantus is actually working, because it takes 2 hours for it to even start working, before we shut that insulin drip off that has a half-life of only 10 minutes. So we need insulin on board before we ever make any other plans. Okay, so comorbidities. So I mentioned gastroparesis. What is gastroparesis?
It is a non-moving stomach.
Yes, exactly. So it could be the stomach or the intestines. So it goes back, it's an autonomic nervous system dysfunction. And what it means is the signals that tell the stomach and the intestines to empty, they're no longer emptying. So food just stays. So for example, a patient went to his doctor, they did an emptying scan. Doctor came back to the patient and said, "Sir, when was the last time you had a hamburger to eat?" Patient goes, "Well, doc, it's probably been a couple weeks." Well, it's still sitting in your stomach. Now, imagine if you would, gastroparesis, if you're trying to eat something on top of a stomach that's already full. You're going to have a lot of pain and discomfort because you can't do that. So many people with gastroparesis don't eat very well. And especially if they eat the wrong things. If they eat high-fat foods or high-fiber foods, which guess what? Our diabetics, we teach them lots of high-fiber foods, right? So we have to unteach them how to actually eat. But if they have gastroparesis, they also have this problem. They come in and they have the exact same symptoms oftentimes as DKA, or they may already be in DKA, because we're going to have nausea, we're going to have vomiting, and we're going to have abdominal pain. And those are similar systems or symptoms to DKA. So if I have somebody in class and they're from the ED, I do like for them to ask this question of the patient: which came first? Did you start vomiting and your blood sugar went up? Or did your blood sugar go up and then you started vomiting? Because that's going to tell you immediately if a gastroparesis exacerbation actually triggered the DKA. Because remember, physical stress causes blood sugar to go up, okay? So we've got that going on. What about kidney disease? What is the role of the kidneys and insulin? And specifically, duration of insulin. Okay, we're like, we roll, tell us, okay. So, me being the kidney person that I've known this for a long time, the kidneys help the body eliminate extra insulin that it doesn't need. And so whether I am secreting endogenous insulin or I'm giving somebody exogenous insulin, either one of those, if my creatinine level or my GFR is low, creatinine high, you can bet that there is a prolongation of the duration of action of that insulin in my system, which becomes, again, very important in preventing hypo or low blood sugar with your patients. Onset, peak, and duration of action. In almost every single diabetes class, they want to present the posters and they're going to show you all that stuff. No, this is about knowing why you actually have to know that. And some of this, I think we're getting across as to why it is so important to actually know these things. We typically give a rapid-acting insulin to somebody before a meal. And you remember okay, don't give them their rapid-acting insulin until the food tray's in front of them. Well, that's because food typically peaks in an hour. Those insulins typically peak in an hour. So if I match my peak, I get better overall glucose management with those particular drugs. Correct timing. So I still remember the type 1 diabetic that we almost killed. I hate to say that, but it could have ended up in that, right? Because of one simple error. So in today's world, it's not about new orders that I can't read from, the writing, I don't know what it's saying. Today's errors are actually one click away, and that's what happened in this particular case. An order was placed for a long-acting insulin, and it was put in as BID AC versus BID, which are right next to each other. Okay? Now, this patient, long story short, had been given a long-acting insulin at 2:49 in the afternoon. He was walking in at 5 o'clock, and he was about to give another dose of a long-acting insulin because it was ordered incorrectly and it was not given, the original dose not given as quickly as it should have been given initially on that particular patient. Now, this was a patient that had had a stroke, they were nonverbal, they couldn't speak for themselves. Now, luckily, there's one other person who at least knows the diabetes clinical picture of your patient. That would be me. And luckily, I was in the room and we stopped that error from occurring to that individual. Because I was like, why do you have 2 syringes?
But does the pharmacy have to verify the orders? Did the pharmacy not catch that mistake?
Well, let's think about that. I've got an order that says BID-AC. Maybe they catch it, maybe they don't, because sometimes doctors do what I call insulin regimen renegades. So they have some unusual patterns of when they actually order their insulin to be given. So for example, NPH, we usually see that BID-AC, but some want it in the morning and at bedtime. Some want to give it to that patient 4 times a day. So it really depends on what that doctor wants to do. So there's many errors when it comes to ordering medicines that will never be caught by pharmacy because of that. Okay. I know it's supposed to be a layer of protection, but it's not always there. Okay. So, what are we going to do with this case scenario? Has anybody ever heard of morbidity and mortality that doctors do? M&Ms. That's what we're going to do with this case. This case happened here at St. Vincent, and after we discussed some of those inpatient or clinical picture things and what do I need to use to make decisions. So there is an error that occurred with this particular patient, but I want you to find it. And we're going to test a little bit of your diabetes knowledge and management skills by looking at this particular case. So let me introduce you to this patient. 33-year-old patient with type 1 diabetes who also has gastroparesis. So first sentence, I already know how much insulin is she making? None or less than 5%, more than likely none. Her comorbidity is gastroparesis. So already we kind of know that maybe she doesn't eat a lot, especially if she's having an exacerbation. And sometimes that's very important to ask your patient if it's something that, is it just a history of, or are you having to deal with something right now because of it? So this patient presented to the hospital in DKA with nausea and vomiting. That was corrected with our IV insulin power plan. So power plans is just our computer system's way of saying an order set, okay? So these are like a sepsis order set or what have you. And also DKA power plan because that's gonna help correct our electrolytes. Now, the story really does not begin in the critical care unit. It begins when the patient is transferred to the floor. Patient at home was on 22 units of Novolin 7030, which is similar to Humulin 7030, which is what we now have. Sub-Q AC breakfast and 18 units of Novolin Sub-Q 7030 before supper, prior to admission. Okay, so that's what she's on at home. The physician, when she's transferred, decides to go ahead and restart those home medications. We know that the patient is still complaining of nausea. She is not currently vomiting, but not eating very well. And when I say that, she's skipping meals. Her idea of a meal is maybe a small container of yogurt. That's what she's eating. Glucose levels currently are in the 200s when that insulin's restarted. She also has Novolog, her medium dose correctional scale, sliding scale, ordered before meals. Now, something's wrong with this picture. This is your patient, and what I say is these new orders have come down. They're on your screen, and what is your job to do with those new orders?
Reconcile.
Reconcile them. You want to make sure they're appropriate. So it's not so much, again, it's not because I can't read the order, but when you have new orders that are placed, you have to make sure that it's appropriate for your patient and their clinical picture. You know, I remember you'd have two doctors, they would order the same thing and they didn't look back to say, oh, that's already been ordered. Well, hopefully you catch the nurse and they go, I don't think we needed 2 of those. Let's not do that, okay? So it's our job to make sure that whatever is ordered on this patient is appropriate. Now, this is what's been restarted. In your opinion, is this appropriate for this particular patient? Okay, so I've got some shaking head no. Tell me why you don't think it's appropriate. What part of this does not make sense to you?
The glucose level is still 200 though, even you're using the home, if you restarted the home insulin. So that made me think that it's not working. It's not.
Okay, so you're concerned that she's still already in the 200s and that the 70-30 just wasn't working at home, so why are we doing the same thing?
I'm concerned that she's vomiting, not eating, and she's got long-acting insulin mixed with short.
Yes.
Okay. Is that your same concern?
Yeah, and I'm concerned about the medium dose correctional scale when she's not eating.
Okay,
Ditto.
all right. Good catches. Now, let's go and dissect what we're giving to the patient. Novolin 7030 contains which two insulins?
Long acting and short acting.
I don't want to hear that, I want to hear names.
NPH regular.
NPH and regular, okay. NPH and regular. Now, which one is 70% and which one's 30%?
NPH is 70.
She wants to be the star of the class, you notice that? Okay, so 70% NPH, 30% is regular. Okay, now everybody comes in here and they want to go short, long acting. Which one is the short acting and which one is the intermediate acting insulin? Regular is the short or intermediate?
Yes. Yes.
Short.
No, not just yes, you gotta tell me, is it, yes, it's short. Okay, so she's like, yes, I agree. What are you agreeing to? Okay, so regular is your short-acting insulin. NPH is your intermediate acting insulin. That's why it has to be given twice a day because it only lasts about 16 hours max. Now, which insulin treats blood sugar from food?
The NPH.
Gotcha. Regular. Okay, so our regular, our short-acting, or your rapid-acting insulins like Novolog and Humalog, those roles of insulin is to treat that spike in blood sugar from food. Okay? Now, if I were to give somebody regular insulin before a meal here in the hospital, how soon before that meal should regular be given, if I'm doing it correctly?
15 minutes.
That would be your rapid-acting insulin, 5 to 15. Your regular insulin needs to be 30 to 60 minutes before the meal. Okay. Now, guys, I'm about reality and life in the hospital in reality. Let's not do any make-believe. Do we ever know when the food tray is going to actually show up? No. So how can I appropriately time my regular insulin to give that to the patient the way I'm supposed to?
When the tray shows up.
When the tray shows up, that's reality. So what happens if my patient does not have gastroparesis? Their blood sugar peaks from the meal here, but regular peaks in 2 hours here when the blood sugar is on its way down. So we can actually have hypoglycemia occurring following that meal if I give regular insulin incorrectly to a patient who does not have gastroparesis. But our patient does. So we have an advantage. If I actually give regular incorrectly and give it right before the meal, I'm actually going to have better management of this particular patient because their peaks will match. But we do have a problem. Am I needing to treat the sugar from food on this patient?
No, because they're not eating.
No. Okay. So, what is the R in S bar? Recommendation. This is your patient. You're taking care of this patient. You see something wrong. You make that phone call, Ann. I want you to tell me, what do you recommend to that doctor? You have concerns about the medium dose, Kelly, but Ann, you're concerned about the not eating, and y'all are both concerned about that. So what do you recommend to correct this particular order?
Well, I think I would take out the short acting altogether.
You would take the short acting out. Anybody else?
I agree.
You agree, okay. Now, I will tell you, typically, in most of the orientation classes, I don't always get that, definitely not first round until we duke it out for a while. But most people, their inclination is to just lower the dose. Well, let's just take the dose down a notch, because they're not recognizing that we don't need the component to treat the blood sugar from food. And then I have some individuals who say, well, let's not even do any of that. Let's just give them sliding scale. Except my answer to that is
We're type 1.
typically, right? So typically, sliding scale, the doctors are ordering just before meals. But if the liver is giving us sugar all day and all night long, I don't have anything to cover that sugar that's occurring in the middle of the night. So can we go into DKA while this patient is sleeping if we're only treating with AC? Now you can do correctional scale every 4 hours if I'm doing, say, our Humalog here, or every 6 hours if I'm doing regular. But then let's look at the role of correctional insulin. If I'm trying to prevent the mountain of sugar from forming, I'm going to give them a scheduled pre-meal dose for their food, and I'm going to give them a basal or longer acting insulin to control that sugar that's coming from their liver. That's going to prevent that mountain from forming. Correctional scale is not about preventing the mountain from forming. The mountain's already there. And all it does is it chops the top off of that mountain and keeps it from overflowing, getting too high. So we don't want Pike's Peak. You have a question? Okay. Okay. So that's what's going on with correctional insulin. So we can do that, but we're really not going to be too much ahead of the game. We're probably going to stay right around here, and we're not going to ever get to our target. So if we want to get to our target, we need to absolutely recommend an intermediate or longer acting insulin. So what would my choices be? Lantus? Yes, I can do Lantus 1 time a day, sometimes 2, it depends on your patient. But it's usually given once a day. I have to remember that Lantus lasts 18 to 24 hours, so that's why it typically is only given once a day. But this patient has money issues. So we're going to stick with something that's not $300. We're going to do NPH. So we're going to do it how often and when?
Twice a day.
Twice a day.
AM and PM.
And you can say AM and PM, but if you do that, this is how it's going to be ordered. It's going to be ordered at 9 to 9, and I don't necessarily want that. I need a little bit shorter time span between that dose, and I don't want to give it so close to bedtime that they end up with lows during the middle of the night, because that happens a lot. Because guess what? Many times the orders on a Novolin 70/30 to that patient says AM and PM. And guess who has low blood sugars during the middle of the night? They have really high by supper, because it's gone, and then they are really low in the middle of the night. So we don't want to time it that way. So we're going to time it BIDAC, okay? So that's going to be our recommendation. Now, let me tell you what happened to this particular patient, because this is real. This is what happened here at this hospital. I am reviewing the chart 2 days after they had restarted the home medication. The reason my little light bulb went off is because that evening at 9 o'clock, their blood sugar dropped to 68. There was no documentation that a provider was consulted. There was no documentation that there was a treatment for that low blood sugar, and there was no documentation of a follow-up blood sugar to make sure that their sugar was above 70. Okay? Now, for 2 days, every nurse continued to give these prescribed medicines without one consideration that something wasn't right. The next day, blood sugar, I'm assuming the nurse probably gave the patient but didn't chart it, gave something because blood sugar was back to 115. But I'm calling the nurse for clarification as I'm reviewing this because I want to know why the 68 happened. So I'm calling her and she's like, I'm right in the middle of treating another low blood sugar on this particular patient. Only this time the blood sugar is now 29. This patient has hypoglycemia unawareness. They can't tell you if their sugar is low. Very dangerous type of patient to take care of, especially on the night shift. They're not going to wake up and say, hey, I don't feel right. Just because they don't have symptoms does not mean that they are not losing brain matter. They are. So we have to be very much aware of trying to prevent this from happening. Now here's the caveat, okay? You asked a very specific question about, didn't the pharmacy catch this? Okay, so this is something that you all need to be aware of. As far as medication errors go, 50% are caused by insulin. And it's not IV insulin, it's subcutaneous insulin. 50%. But in my next breath, I'm going to tell you that we no longer require you to actually do a second nurse verifier after subcutaneous insulin doses. Does that shock anybody? Especially when I tell you, hey, all these errors are occurring with insulin. Why are we taking out a check? So let's go back to this scenario and even the one you asked about, okay? The first line of defense is the physician writing the order. Should they catch their own mistake? Yes, if they go back and review the orders that they placed, maybe he would have. Then it goes to pharmacy. This looks like a perfectly acceptable insulin regimen as far as pharmacy is concerned, because do they know the clinical picture of the patient? No. Then it goes to the computer system. We're going to do that scanning. Is my computer going to catch this medication error? Guess who is last to be able to catch that mistake? It's going to be the nurse taking care of that patient, who also should know the clinical picture of that particular patient. Now, before we had this discussion, I want you to think honestly about whether or not you would have caught this particular error and questioned it before we went over all of that information about the clinical picture. I've got Mr. Honest over there, like, nope, not giving it. Okay, and I would say that, go
Because
ahead.
there was nothing that would have flagged you, it was a mistake, and
Yeah.
you're caring for 6 or 7 patients.
That's your flag.
Well, if you reconcile it, there's still not anything that's gonna flag it as a mistake.
Not if you're waiting for something to wave a flag at you. No, there's only one flag that exists, and it's within your own critical thinking skills and ability to examine what's going on with this particular patient.
In my mind, there is a big red flag. The patient's nauseous and is not eating. And for me, that's not the patient we dump a bunch of short-acting insulin on, period. I don't care what it is that they ordered, but it's, if they're not eating and they're
Right.
diabetic, that's not the patient.
And some nurses are not comfortable being able to recommend something but every nurse should at least be able to express their concern.
Yes.
They may not know what the right answer is, but hey doc, I've got this patient, they're not eating, but I'm really worried that we've got them back on their same home medication dose. Now, this is what you need to know about this case as well. As I'm going through the progress notes and trying to do the timeline on this, the physician specifically on the day he ordered this insulin wrote that he had ordered NPH BIDAC, not 70/30, NPH BIDAC. He made an error that he was not aware of, and no one else behind him caught it. And really and truly, the only other person who can catch that is going to be the nurse taking care of that patient. It is not good enough to just say, well, it was ordered, so I'm going to give it. Or there's nothing that says this isn't right, because the majority of medical errors when it comes to insulin is not about being flagged by the computer or even pharmacy. Pharmacy misses a lot of things. And I could go days and days for telling you things that get through our system and get to reach the patient and puts them at risk. Okay, so now.
So this could have been caught in the bedside shift report.
Yes, it most definitely should have been covered in bedside shift report. And actually to get the attention of the physician, we actually had to get pharmacy consulted and get them into the thing for him to even realize what the error was. The reason I show this one is because I just want everybody to understand what is not only available within the hospital. So those that are in our current formulary are bolded. So if you see a bolded insulin, that's what you have to learn. That's what I want you to concentrate on as far as learning onset, peak, and duration of action. Because you have to have that piece to be able to critically think through your clinical situations. Now, notice also I've got these divided into food, liver, and combo. So correctional scale is for those that eat too much, they're sick, or they've got a stressor, there's something going on over there, okay? Some sort of illness. You also need to be aware that there are insulins that have multiple concentrations now. So Humalog is not just U100, it's now U200. Tresiba is U100, U200. Regular has a U500. So probably the only one in-house that will be on that is going to be your insulin pump patients. Sometimes they will have that in their insulin pump, but it's important to know what they're actually getting. We had a patient that she was on U500 at home and kept having problems with hypoglycemia. What we discovered through a lot of investigation was the fact that she was using the wrong type of insulin syringe. So you have to use a U500 insulin syringe to administer this. She never went and picked hers up. So she's at home using traditional insulin syringes and giving herself entirely too much insulin. So even before they had those, they had to draw it up in a tuberculin syringe and do a calculation and convert it to volume versus units. So luckily we have pens now and everything else. There's also an inhaled insulin that's available. The first one that they had was called Exubera, and the inhaler was about this tall and this wide out to here. It didn't last very long due to, I don't know, lung issues. But now they do have another one that is available. It is only rapid-acting insulin. Now the size of this inhaler is about the size of a whistle. Okay? Unfortunately, it's very expensive, and insurance companies say, you have all these other choices, I'm not paying for that. Okay. these are some of our extra long acting insulin. So they typically stay in the system for 36 hours. So one of the problems with Lantus is because it can get out of the system at 18 hours, which is common, you have a breakthrough of high blood sugar when you're taking Lantus at times. So any questions on some of that stuff?
So if a patient is admitted to the facility and they use a pump at home, do
Uh-huh.
we keep them on their pump?
Very good question. It's a depends. So,
It's 2 a.m., the nurse admitted a patient with a pump. The answer is,
no.
okay.
I say that and then I should probably back up. So things that we look at is, number one, is the patient capable of managing their own insulin pump? We have very few people who have been trained on insulin pumps here within the hospital, especially now that we don't have endocrinology coming into the hospital. So I know how to work a pump. I knew that endos knew how to work a pump. We've had some of the pharmacists trained on at least looking for the settings within the pump. Another thing that is a problem is supplies. One of the things I had to do last week for an insulin pump patient was I first called Endo Clinic because she needed supplies and her husband couldn't bring them to her. I ended up calling the insulin pump educator who came up here and brought me extra supplies for the patient. So we don't always have insulin pump supplies to give to the patient, and there's a lot of different pumps out there. So I had one for in Cabbage. She knew how to do things like temporary basal rates, and I mean she was able to manipulate her pump quite well, much better than some. A1C of 6%. So that's somebody that I don't mind having them on their own pump as long as they're not too sleepy, too drowsy, they're with it enough. Are there some patients it's just better take them off their pump the whole time they're here? Absolutely. So it's very much a judgment call. A big question is always in the OR. So that may depend on how long that procedure is going to take. Again, they can't go very long without insulin if they're a type 1 or very insulin dependent. And if you're a type 2 on a pump, you've had to prove that you don't make enough insulin. Okay? So, to answer, I guess that sort of answers your question. It really depends on the case. Okay, something I like to go over very briefly is how do you get a consult with a diabetic nurse specialist? So I am a physician's order only. So if I have, or if you have a patient that you're concerned about that may need education by myself, then you want to make sure that you put in the order consult diabetic nurse specialist. Now, common sense would say you could put in diabetes education and that should get you the diabetes educator. However, you have placed a consult, but you placed a consult for yourself, and I'm never going to see it. So it shows up on your task list, and it does not show up on mine. Sometimes when we get new docs, they don't know this, and they're like, I've consulted that diabetes educator. I'm like, no, you didn't. I had no clue about your patient. So anyway, just be mindful of that whenever y'all are out there. If you do need to get a hold of me, that is my office phone number, and now I'm on Skype. I don't have that up there, but I also have this, although evidently I need to plug it in and get the battery charged, and that's my email. So I do try to check that in the morning before I get busy with my patients during the day. I do have a priority list because I oftentimes have to spend a lot of time. With the new onset who's going home on insulin, their priority number 1, I spend a minimum of 3 hours with those individuals. New onset, that's my next one. New to insulin, that's probably going to be my next one, especially if they're going to go home on an insulin pen. I spend a lot of time to make sure that they know how to do all that correctly. Unfortunately, uncontrolled diabetes is down there on the list. Sometimes they are exactly like a new onset though, and sometimes you have to spend almost as much time because they may never have been educated by anyone. Again, insulin pumps, I get consulted mostly to go verify the settings, make sure it's appropriate for that particular patient, and then advise the physician whether or not we should put the patient back on the pump. So if I'm not here, that means the diabetes education needs to occur by that primary care nurse. Okay. Any questions so far? All right. This is where I say thank you for keeping all of our patients at St. Vincent's both safe here and when they go home.